Thank you, Shivani. A very good evening to respected panelists, respected senior doctors, dear colleagues, and dear juniors. Myself, Dr. Ramanand Chaudhary from BH. I'm a third year resident under NOS. So today I'll be talking about idiopathic intracranial hypertension. So as the name says, idiopathic, it is causeless and is characterized by the elevated intracranial hypertension pressure in the absence of an intracranial mass or obstructions. So it is also named as pseudotumor cerebri, and the key features here is the papillary edema with normal neuroimaging. But when there is acute visual threat, the condition can be described as fulminant idiopathic intracranial hypertension. So, who gets IH? It is much more common in female, approximately 90% of the cases. Among them, it is more common in obese female, about 90% of the cases, and it is highest in third decade of life. And it is rare in prepubertal children, men, and lean adults. So it has strongest associations such as hypervitaminosis, especially with the vitamins A, retinoic acids, and some antibiotics such as tetracyclines. It is also associated with the comorbidities such as sleep apnea, anemia, and it is strongly associated with the hormonal factors implicated by the pregnancy. However, there is no link with the endocrinological dysfunctions. Now coming to the clinical presentations, so the most common presenting symptoms, the patient will complain of the headache, which occurs due to the raised intracranial pressures, and it is often associated with the nausea and vomiting. So the most common visual symptoms is the transient obscurations of the vision, which is one of the classic symptoms of the papillary edema. And they usually last seconds but can persist longer. And when the obscurations are prolonged or spontaneous, the papillary edema is more threatening. However, the visual acuity is not affected by the papillary edema unless the papillary edema is severe, long-standing, or accompanied by the macular edema and or retinal hemorrhage. Other associated features are diplopia due to the sixth cranial palsy and pulsatile tenderness or neck and back pain. So the ocular manifestations which we can see ophthalmoscopically is the papillary edema. And this papillary edema occurs due to the impairment of the exoplasmic flow. So the papillary edema has different signs such as mechanical signs and the vascular signs. So this is the picture of the optic disc in which the mechanical signs like blurring of the disc margin is seen. The elevation of the optic disc from the adjacent retina is clearly seen, and the vascular signs such as the hypertonic disc as well as the venous condition is seen. However, there are some secondary causes leading to the IH. These are cerebral venous thrombosis, extracranial venous obstructions, dural AVM, and systemic vasculitis. But while figuring out the secondary causes, we never have to miss the venous sinus thrombosis, and it actually presents in case of the atypical patients, like the male patient with lean and thin, elderly patients, the patient who has a recent history of childbirth, the history of female with history of hormonal contraceptive use, and recent ear or sinus infections. So the workup need to be done here is the proper history taking, the general physical examinations such as the BP measurement, along with the neurological examinations, and the ophthalmological examinations such as measurement of visual acuity, color vision, and contrast sensitivity, the pupillary examinations, ocular motility and alignment to detect the sixth cranial palsy, and the fundus examinations should be done by the full dilation of pupil to rule out the papillary edema and of course the intraocular pressures. Now coming to the diagnostic test, there are various diagnostic tests which can be done. And among them, the most important test done in our ophthalmological setting is the visual field testing. So this is the visual field of 30-degree visual field, and this is the center of the fixations. And this is the grayscale map which shows the normal visual field with the normal physiological blind spot. However, in this picture, there is the enlargement of the blind spot due to the papal edema, and on the subsequent phases, there will be the peripheral constrictions. And further, on the late stage, there will be generalized peripheral constrictions leading to the tunnel vision. Now, the other diagnostic test is done by the MRI brain. Here, the evaluation of the papal edema requires neuroimaging to exclude an intracranial lesions, and it can be done with the use of contrast to rule out the specifying mass or hydrocephalus. And another is the MRV can be done to rule out the cerebral venous sinus thrombosis. So MRI will show the flattening of the globe, emptiness of the cella might be completely empty or partially empty. There will be the transverse venous sinus stenosis. There will be the tortuosity of this optic nerve, and there will be the protrusion of the intraocular portion of the optic nerve leading to the papal edema. The other test that can be done is the lumbar puncture, which shows the high opening pressures. The pressure will be more or less 225 centimeter of water. However, the composition of the CSF will be normal. And often this is done repeatedly to treat the headache, but it should not be done as well. Now, the modified Dandy's criteria, which are the increased sign and symptoms of increased ICP, the no localizing or focal neurological deficit other than the signs of sixth cranial palsy, and the increased opening CSF pressures. However, the composition will be normal with the normal neuroimaging. This is the revised Friedman criteria, which is actually categorized into the four diagnostic subgroups. First is the definite IH. Definite IH is actually when there is the presence of papal edema with the opening pressure of more or less to 25 centimeters of water. And it can be categorized as probable when there is the papal edema, but the opening pressure with the LP is less than 25 centimeters of water. And the definite IH with papal edema when there is the opening pressure more or less to 25 centimeters of water, and the presence of efficient no palsy. And the suggested IH with papal edema when there is the opening pressure of more than 25 centimeters of water with three or more out of 4 signs of neuroimaging. So the ophthalmic monitoring in IH is very important to look for the progression of the papal edema. So first we can do is the visual acuity and color vision test in every visit. However, the central acuity declines in the late stage. And the quantitative perimetry, which can be done at different frequency according to the severity of the papal edema and the treatment response. And another is the optic nerve weight photography for the documentation of the papal edema. And another is the OCT to look after the retinal nerve fiber layer thickness and ganglion cell layer thickness. So the medical management, the first line therapy is the weight loss. So weight loss of about 15% is curative in this case. According to the Idiopathic Intracranial Hypertension trial, which was done on 2014, confirmed that the efficacy with the weight loss for the mild to moderate visual field effect is effective. For the weight loss, we can also refer the cases for the nutritionist, and if the weight loss is not controlled by the nutritionist, we can also refer to the pediatric surgery. Other medical management is the acetazolamide. It can be started from 125 to 250 milligrams per oral in the BD or TID dose, and further it can be increased up to 250 milligrams per day until the symptom improves or side effect occur. It can be given up to 1 gram per day, which is usually tolerable, but the upper limit is 3 grams per day. And in some patients, like very obese patients, it can be given as 4 grams per day. However, we have to keep in mind that this drug has very severe side effects such as hypokalemia and metabolic acidosis. So we have to look after it. So other drug is the topiramate, which is also actually the carbonic anhydrase inhibitors, but it helps in weight reduction by suppressing the appetite. Other drug is furosemide. So we have to avoid the chronic use of corticosteroids, as the recurrence of the corticosteroids can as the tapering of the corticosteroids can cause the recurrence of this disease, and it can also cause the weight gain, which can worsen the disease. And repeated LP is also avoided. The surgical options are optic nerve sheath penetrations, which can be done if the visual loss is severe but without the presence of headache. Other is the CSF shunting, such as lumboperitoneal or ventriculoperitoneal shunt, and the venous sinus shunting in case of the transverse venous sinus